I'd like to introduce our moderators for the next session, Dr. Sanjiv and Gaurav Lakhanpal, and this session will be devoted to pelvic venous disorders.
Thanks, Peter. Guys, it's my distinct privilege to introduce Kathy Gibson. Kathy is with the Lake Washington Vascular Surgeons, and more importantly, we've known Kathy from all her active participation at the AVF and AVLS. She's given us so much data to ponder on and learn from. Kathy, thank you very much for being here. All yours.
Well, thank you for inviting me. I'm delighted to be here. I can't wait till we can all be together in person again, and it's wonderful seeing old friends on video and maybe some new ones. So I want to apologize in advance that my presentation, some of the formatting may be a little bit off. I changed backgrounds, and I noticed last night as I was practicing, some of the animation is off. So I apologize, and hopefully you'll pay attention to my words and not distracting visuals. So that being said, let me see if I have control of the screen now to advance. So what I'm going to go over with you today is, I think, a good introduction for this session, because I'm going to talk to you about the SVP classification for pelvic venous disease. And these are my disclosures, and you may have seen a lot of these slides before if you've been at the AVLS where this was first presented. And part of it is that it's kind of a slide deck that our working group uses, and I just tweaked it a little bit. So some of these may be familiar. And in that tweaking, I screwed up some of the animations. So again, I apologize. But this is one I put in, a cartoon that kind of shows you what one of the problems is when we are talking about pelvic venous disorders and pelvic venous disease, is we don't have a really good classification tool, so we're not always speaking the same language. There's not consistency when you look at papers in outcomes, because sometimes we're comparing apples and oranges. And so this is really getting a tool where we can speak the same language when we're describing pelvic venous disorders. And there are really, want to focus on 4 clinical presentations that we see with patients. So patients with pelvic venous disorders sometimes come to our practice because they have chronic pelvic pain, which is a non-cyclical pelvic pain that lasts over 6 months of duration. And with this, there is often pain, dyspareunia, dysuria, and sometimes some other symptoms. Sometimes patients come to us with pelvic varices. Actually, this is the way that patients are most often sent to me, is that a provider or the patient notes that they've got vulvar or gluteal or perineal varices, and they come to me, and when you talk to them, you find out that they also have pelvic pain. Some of them do, some of them don't. So that's another presentation. Some patients present with renal symptoms of flank pain and hematuria, and at least in my practice, this is the least common clinical presentation that I see. And then finally, and this is more kind of with obstructive symptoms in general, leg pain and swelling. So there are these 4 clinical presentations, and here's an example of my screwed up animation. So I apologize, you've got some kind of overlaying here. 2 main patterns of reflux that we see. We see ovarian vein reflux is shown in this laparoscopy. You see this big bulging varicosity around the fallopian tube, and internal iliac vein reflux. And these kind of can be both present in many patients. And then there are a couple patterns of obstruction, either renal vein obstruction or iliac vein obstruction. And this can be the left or the right side, although as we know, the left side is more common. And obstruction can also lead to reflux. So you can have both patterns present. And this kind of just confuses the situation further. So research priorities in pelvic disease, and I just noticed this morning, Neil, your name is spelled wrong, Neil Kulnani, if he's still here on this. So it'll be corrected in further slide decks going forward. But this all was kicked off by a meeting that was sponsored by the SIR Foundation in October of 2017, so just over 3 years ago. And this was a panel, a multidisciplinary panel that Neil Kulnani put together, that involved interventional radiology, OBGYN, phlebologists, vascular surgeons, pelvic pain specialists, and some that had expertise in clinical trials. And the purpose of this meeting was to talk about and develop research priorities in pelvic venous disorders. And this used what's called a BORDA algorithm for the group to identify research priorities. So this is a layout of what the top 5 priorities were. And what I'm talking to you about today with the SVP is what I've been really involved with, and Neil has as well if he's still on the talk. And this was this priority was to develop a discriminative tool for pelvic venous disorders, so somewhat like the SEEP classification for superficial veins in the leg, or the TNM classification that is used for cancer. So after this research priority was identified, then the next step was actually sponsored by the American Vein and Lymphatic Society. And we had a meeting in Chicago on July 27th of 2018. And the contributions from these different groups, we had members of these different groups that worked on this together. So this was really international and multidisciplinary. And our goal was to develop a reliable and valid classification system that places patients into bins with similar clinical features, natural histories, and responses to treatment. So this is not a severity score. This is a bin system to categorize the different patients we see. So you could then, for example, in a research project, decide which groups you want to look at, or have a definition of the different patients in that way. So we came up with the SVP classification, and the way I remember it is like s'il vous plaît, SVP. And so the 3 parts of this are symptoms, varices, and pathophysiology. So I'm going to go over this with you. And the pathophysiology part has some subdomains, which we'll talk about. So with pelvic venous anatomy, there are 4 interconnected systems. We have the left renal vein, we have the gonadal veins, the internal iliac veins, and then the veins of the lower extremity, which connect through pelvic escape points. So these different pieces of anatomy go to different pelvic venous reservoirs. So the first reservoir is the renal pelvis. And in this area, if you have obstruction, you can get renal hilar plexus varices, and these can lead to symptoms in the back, for example, in the flank. The pelvic plexus, what we call the transitional plexus, so these would be varices that you see in the vulva or scrotum. And then finally, the lower extremity. And the symptoms that patients develop are really related to distension, either from reflux or obstruction of the plexus, any one of these plexuses. So the pathophysiology, again, that we talked about before, you can have reflux, either gonadal vein or internal iliac vein, or obstruction, renal vein, iliac vein, or both. And what we don't know is why similar symptoms arise from different anatomic lesions. For example, you could have a left renal vein compression that does not cause renal varices, but perhaps transmits pressure into the pelvis and the symptoms are there. Or you can have pure gonadal reflux and have pelvic pain, or you could have a common iliac vein compression and have pelvic pain. So what likely this is compensated versus uncompensated hemodynamics. Just like we see patients sometimes with a completely occluded common iliac vein, and they've got massive collaterals and no swelling in the leg, so they've compensated. So the symptoms really relate to that kind of distension of the reservoir and whether there's compensation. So the SVP classification, which I know you're excited for me to kind of lay it all out, but first I'm going to tell you, this has been written. The lead author is Mark Meisner. The final manuscript is in review, and it says planned publication fall of 2020. It's now winter 2021, but it is in at the Journal of Vascular Surgery, Venous and Lymphatic Disorders, and Phlebology, and it is anticipated that we will be published in both online very soon. So look for that, but you're getting a preview today. So getting back to this classification, there's 3 domains. The first one is symptoms. And this would be where the symptoms are that the patient's having. The second domain is what is the variceal reservoir? So where are there varices? So it could be the renal hilum, it could be the pelvis, it could be the transitional varices, or it could be atypical varices in the leg. So that's V. And then finally, pathology, and there's 3 subdomains: anatomy, what the hemodynamic abnormality is, and etiology. And we're going to get to that on another slide. So the instrument reads SVP, AHE, and this will become clear. I'm going to give you some examples. So looking at the S for symptoms and V for varices, we have identified 4 anatomic zones of the pelvis. So zone 1 would be where you would have symptoms or varices is the renal pelvis. So the patient's symptoms would be flank pain or hematuria, and the varices would be seen in the renal hilum. Here's another example of my screw up on the animation. So again, I'm sorry for that. The second one would be zone 2, which is in the pelvis, and the patients with symptoms in this area would present with chronic pelvic pain, and the varices would be in the pelvic venous plexus. Zone 3 is what we call the transitional zone. So this would be the vulva or the scrotum. And you would see either vulvar varices, varicocele, or atypical varices in this area. And then finally, zone 4 would be in the leg. And here, if a patient's got varices in the leg coming from the pelvis, we would also use the Hashd symptoms, heaviness, aching, swelling, throbbing, itching, to describe those patients. And you would see lower extremity varices. So the subdomains, the S and V, I think, are pretty easy. Where are the symptoms? Where are the varices? The A, H, and E, A is simply anatomy, names of the veins that are involved. And this table is on Zoom, looks pretty little, but it's a description, just kind of abbreviation of different veins. The H, pretty easy, hemodynamics. It's either reflux obstruction or both. And then etiology, non-thrombotic, thrombotic, or congenital, like a congenital malformation. So this would read like a sentence. For example, you would have, this is showing a P of a patient with a, what we used to call May-Thurner or a nivel. This person would have a non-thrombotic left common iliac vein obstruction. That would be a P, and then you list the vein that's involved, that it's obstructed, and non-thrombotic. So I'm going to give 2 examples. So a patient with what we used to call pelvic congestion syndrome or pelvic venous reflux, if this patient presented with pelvic pain and bilateral gonadal vein reflux, their SVP classification would be S2, so symptoms in the pelvis, V2, varices in the pelvis. Then reading the P, both gonadal veins are involved, they're refluxing, and it's non-thrombotic. Another example, this would be a left renal vein compression, and say this patient did not have flank symptoms, say that their symptoms were in the pelvis. They would have S2, symptoms in the pelvis, V1 and 2, because on this venography you see that they do have varices around the renal hilum and in the pelvis. So V1, 2. The pathology, you'd list them in order from top to bottom of which veins are involved. So left renal vein is obstructed and non-thrombotic. Left gonadal vein is refluxing and non-thrombotic. Bonus, I'm going to give you 3 examples, not 2. So left common iliac vein compression with pelvic symptoms would be S2, symptoms in the pelvis, V2, varices, or in this case, collaterals in the pelvis. And then the pathology is the left common iliac vein is obstructed and non-thrombotic. The left internal iliac vein is refluxing and non-thrombotic. So this is something that at first sounds cumbersome, but remember learning SEEP for the first time, a little cumbersome to remember, especially the E, A, and P of SEEP. But you know, this is a common language we use for superficial veins in the leg. You can say to somebody, I've got a SEEP 4B patient clinical class 4B, and in my mind, I have an idea of what's going on. And if you include the EA and P, I really know what's going on with that patient. I have a picture in my head. So hopefully this will be the same way once people have practiced. So what are our next steps? First off, the paper, I think any time now soon should be out. This was presented at the AVLS meeting virtually this fall, but I encourage you to get this paper, and I do believe it's going to be open source. If Neil's on, he could let us know that. He's with phlebology, he edits phlebology, and he can maybe tell us on the panel. Then the AVLS is going to do a workbook. So that's going to be online, where it's, you know, and I'm hoping we can get some CME attached to that, but it'll basically be kind of a didactic sort of like this. And then there'll be case examples you can work through, and you can put in what you think the classification is, and it lets you know whether you're right and wrong and kind of discusses that. So an interactive workbook to learn how to do the SVP tool. There's a phone app that Tony Gasparis has been developing both for the iPhone and the Google Android, much like Dr. Cabrini has one for his classification. This will be kind of a similar thing that you can classify patients using an app. We're hoping to have some more webinars and roundtables discussing this. And then the next step for our group is developing a patient-reported outcome tool for pelvic venous disorders. And this is a heavy lift, but something we're pretty excited about, and we're having you know, psychometrists help us develop this. So that's something that is kind of our next step following SVP. So in conclusion, this SVP classification, pelvic venous disorders, those of us involved in taking care of these patients, it's exciting because there's so much for us to learn that's out there. This is really a field where we really need to know more. And these disorders are complex. You can have similar clinical presentations with different pathology, similar pathology with different clinical presentations, and patients that present with both obstruction and reflux. And, you know, we're trying to piece together, you'll have some talks about this later, about what order we should be treating things in, or whether everything needs to be treated. So the historical syndromic nomenclature is misleading. And I really do have to peel myself back from talking about May-Thurner syndrome, pelvic congestion syndrome, and nutcracker, and really talk about this more in anatomic terms of like non-thrombotic iliac vein lesion, renal vein compression, et cetera, that we want to get away from the syndromic names. This lack of precision in classifying patients leads to poor treatment outcomes if you don't really know, kind of have a language of describing these patients. And it really limits our progress in research because it's hard to do anything like a meta-analysis or compare papers when we're all over the map when we're talking about these different patients. So this discriminative instrument is desperately needed. It is complicated, but pelvic disease, again, is complex. And this is what was a criticism of the SEEP classification when it came out. It was too complex. People wouldn't use it, and I think we use it a lot now. So again, read and reread the manuscript, use the app, and what I'm doing now is I'm practicing it on my patients. And I don't have this as a kind of radio button thing in our EMR. I wish I did, but I write it out when I'm seeing these patients so I can get more used to using it as well. So I thank you for your attention. And again, I apologize for the screw up in the formatting. Once I found it, I fixed it, but it didn't make it in time for this presentation. So thank you for bearing with me on that. I appreciate, and I really appreciate the invitation to be here again. Thanks.
Thank you, Dr. Gibson. This was a very enlightening talk. It gives me great pleasure to introduce our next speaker, Dr. Teresa Soto. She is board certified in OBGYN. Dr. Soto currently is the Director of Clinical Affairs at Center for Vein Restoration. She also is the Associate AB VLM Fellowship Director at CVR and holds an academic position as an Associate Professor at VCU School of Medicine. And Dr. Soto shares our passion for pelvic venous disorders, and she'll be focusing on the GYN aspect of pelvic venous disorders. Thank you, Dr. Soto.
Sorry to interrupt, Dr. Soto. It looks like you are not being heard. I see that you are unmuted. You may need to select a different microphone source. In the bottom left corner where the microphone icon is, if you click that arrow, it's a drop-down menu, should be able to allow you to select a different microphone source.
How about now?
Yep, we got you.
Sorry,
We can hear you.
you can. Great, and I've got a wonderful echo. All right. So to follow Kathy Gibson is a big deal. I have been doing venous medicine for about 6 years now with CVR, and to work with all of these wonderfully smart and invested people in chronic pelvic pain, I've learned so much more about chronic pelvic pain in the past 6 years than I did all the way through residency. We have some shared goals with managing chronic pelvic pain. When you look at chronic pelvic pain, it is really common. 15 to 20% of women reproductive age through perimenopause have chronic pelvic pain that's lasted at least 6 months, even up to a year. And for many of these women, we don't actually find a cause, and we go more into pain relief. And that's a really poor way to manage these patients. Because we don't often come up with an etiology for their pain, they are more likely to use medications. They are more likely to have non-GYN surgeries. They're more likely to have a hysterectomy, because the light at the end of the tunnel for so many people is hysterectomy. They're thinking that all of their pain is in and around their uterus, tubes, and ovaries. And like anybody with chronic pelvic pain, women with chronic pelvic pain, they have a poor quality of life. They have kids or not, they have a job, and they're harder to get up and motivated to do, fun things and additional things. Their interpersonal relationships are troubled. They have more depression, and that's more of the medication that we often look at for women who have these chronic pain problems. This should be a symptom and not a diagnosis. There are so many women who walk around with a diagnosis of chronic pelvic pain. It's left at that, and we're hoping we can get them to a point where they're hysterectomy ready and get them to feel better. This is the American College of Obstetrics and Gynecology list of associated symptoms with chronic pelvic pain. I'm so very happy to hear that somebody from ACOG is actually working with Dr. Kalani and with Kathy Gibson to work on a nomenclature for this, because this is a really ridiculous list of what possible things can be attributed to chronic pelvic pain. I'm a fellow of the American College of Obstetrics and Gynecology. I'm still board certified in obstetrics and gynecology, and none of that information has filtered down yet. So we have our usual suspects, our GYN, GI, and urologic systems to look at, along with everything from fibromyalgia to abuse and depression and anxiety disorders, because we know that women are so emotional that so much of their pain can just be hysterical. It's so common that everybody sees this, whether you are a primary practitioner, whether you are a podiatrist, ortho. It affects so many women that it is as common as asthma and chronic back pain in most primary care practices. And it is really a huge reason why patients are referred to gynecologists. This is the American Family Physicians more whittled down list of their workup of chronic pelvic pain. They have the usual suspects, right? The GYN, the GI, the Euros. They put this in here too, pelvic congestion. And from all of the years that I spent training and working as a resident and as a clinician, pelvic congestion syndrome has been a wastebasket term. It's like, yeah, maybe it's that. We saw some varicosities on an ultrasound. What does it mean? What do you do about it? No idea. But we can tell the patients, maybe it's because of this. So it's interesting that it made the American Family Physicians list, but not the GYNs. And it's pretty much because you have to be a good clinician and you have to be open to all the potential suggestions as to what can be causing your patient's pain, and not just push to the fact that it could be endometriosis, adenomyosis, and a hysterectomy is going to make you feel better. So I think there needs to be another category here, the vascular category, that includes pelvic congestion and, of course, May Thurner. So if we whittle down our list a little bit, again, I just think that suprainguinal venous disease needs to be in here. and that a pelvic venous duplex, possibly venogram IVUS, depending on what you find, needs to be added to the workup of these patients. I think we're missing a lot. So we do our history and we try to get a chronology of symptoms. Do you have a family history of it? Pre-pregnancy, post-pregnancy? Do you have any sexual issues, dyspareunia, pain after intercourse? And put as complete a history together as we can. We do their physical exam, we look at cultures, urinalysis, betas, and then we have to consider, so what next? What kind of study do we do to try to weed this out? Cyclic versus non-cyclic pain, just because it's not cyclic doesn't mean that it can't be GYN related, but we usually have a chronic baseline pain with cyclic exacerbations in a lot of these things. So we do all of our labs. We're going to call it a GYN etiology because we can't really find an extra pelvic source at this point. Do you do an ultrasound just to kind of look around and see what there is to see? And for the most part, yes, you do, because your pelvic exam, your bimanual exam is so limited these days. It's always been kind of limited because it's a really uncomfortable exam. But as you get to bigger women, increased abdominal wall sizes, thicknesses, higher BMIs, pelvic exam is really crummy. When you do an exam, if something is big and bulky, you still need to do an ultrasound to see, is that really what I'm feeling? If it's cyclic pain versus non-cyclic, it really doesn't matter. We typically do ultrasounds for most people to try to get a picture of what the organs look like there. And when you do an ultrasound, I mean, it's cheap. It gives you some good pictures. Transvaginal ultrasound can beat the increased abdominal wall problem as far as getting you some good pictures to get a good look at what's going on. So if you feel something, if you can reproduce tenderness, if there's immobility in the pelvic organs, you do an ultrasound, but incomplete or inadequate exam is the #1 reason why we go to ultrasound. So we do our ultrasound, you can see dermoids, fibroids, complex masses, carcinomas. These get in the way every now and then you have to kind of reroute. But for the most part, once you get down to your ultrasound, if you see some pathology, if you see a mass, most of us, depending on how good our sonographer is, can trust when something looks more like endometriosis versus a suspicious adnexal mass. We can do some tumor markers as well. But for the whole, we might do some MRIs to better characterize something that looks suspicious, just so we know what we're looking for, or whether or not we have the GYN oncologist on call to help us do a staging lap. But almost everybody ends up with laparoscopy, regardless of what you see on the sonogram. So we tend to skip the MRI unless we really need to characterize something better. But you have to look at patient symptoms. How severe are they? How often are they? What's their pain score, which is nebulous, right? As Kathy just went over. And to try to put together a potential treatment plan for them of observation and conservative measures versus just going to a scope and trying to figure out if there is something going on in there that we can put our finger on and make better. So pending the severity of symptoms, pending seeing a mass or pathology, most patients will end up with a scope. Okay. Ultrasound's cheap, MRI is a little bit more expensive. We really only use it if we need to know a little bit more about what we're going into there. Obvious things are obvious. You should see this on ultrasound. This is a fundal fibroid that's locked right into the cul-de-sac. This doesn't move very much. And if you've got a really big, thick abdomen, this could feel really normal. Adhesions you won't see on your ultrasound. Hopefully you feel this, but you'll definitely see it on your ultrasound. Adnexal torsion is an interesting finding as well. If you have a really good sonographer and you get a helical look to your arteries and veins along the pelvic sidewall and the infundibulopelvic ligament, that's a pretty good call. This is still healthy, and this can cause a chronic, achy discomfort with exacerbations of really significant knock you down kind of pain. And what this usually turns into is necrosis of the ovary. You kill it and we'll take that out and that'll make things better. A less common finding in chronic pelvic pain. We see these all the time. We put a scope in and look at that great big vein in the infundibulopelvic ligament. You can also see hints of bigger veins down along the pelvic sidewall. In our residency and in teaching roles, like, whew, okay, make sure you really tie that off good so that it doesn't bleed. But as far as the significance of them, nobody really has worked into what is the significance of this finding and what does it mean for this patient for future. This is not going to show up on ultrasound. Do adhesions cause pain? Maybe, if your colon is pulled up and full and has to move through there. This is a frozen pelvis. All of the organs are just locked underneath these adhesions here and they really don't move. So more like an endometriosis picture. These adhesions don't show on ultrasound either. So this is where your scope comes in handy. So once you get your scope in there, you treat your pathology. Lysis of adhesions, does it help? Maybe sometimes. Myomectomy, mass resection, but hysterectomy it's a fine line to walk when, where, and for whom this is the right management. Our biggest problem is when our laparoscopy is negative. You go in, you look, and you say, didn't see anything, which could include those veins that we said, we saw veins, but probably, just generous, right? So at this point, when your scope is negative, you reconsider your etiology, right? You go back through your list of potentials. And I think here, your deep vein center really has to come into the thought process. You can do empiric therapy for some of these women, especially more the younger with the dysmenorrheas. But then how long do you drag this out? So if a patient has had chronic pain for a year and you put a scope in and you still haven't gotten her an answer and now she's in pain recovering and you say, still don't know what it is, but let's try you on more NSAIDs or oral contraceptives. These are the medications that we treat chronic pelvic pain, with medroxyprogesterone, whether it is oral or DMPA, GnRH agonists, danazol, thankfully we've gotten away from. That's a really ugly medication. But then you have to decide how long are you going to treat these patients before you actually look for the answer when they are not completely satisfied, because you'll take somebody with chronic pelvic pain and kind of a crummy quality of life, and you'll give them moodiness, hot flashes, night sweats, irritability, weight gain, acne. So you're really compounding a poor quality of life in many of these women. And if your hope is to try to get them to hysterectomy, this can be a long road for a lot of women. Hysterectomy is not without complications, right? Especially when you've got something like that frozen pelvis. You can get vesicovaginal fistulas, rectovaginal fistulas. You can get into the bladder. You can get into the bowel. They can end up with a colostomy for a short period of time. It's just not something that should be entered into lightly. So in this little study, 2016 Obstetrics and Gynecology, they looked at 9,622 hysterectomy specimens. And what they found is that fewer than 25% of women undergoing laparoscopic or abdominal hysterectomy for a diagnosis of chronic pelvic pain, presumed endometriosis, there wasn't really evidence of endometriosis in many of these women. So, what are you doing and what is your endpoint here? When you look at the American College of Obstetrics and Gynecology, this practice bulletin was updated last in 2018, and it's still exclude your other causes, Uro-GYN and ortho, try some of the medications, and then if all else fails, go on to a hysterectomy with ovarian conservation, remove endometriotic lesions as it applies. But the hope is that it is endometriosis. And as we see, there really is not enough endometriosis to warrant everybody being treated as though they have endometriosis. We need to have this pelvic venous evaluation in here before we commit somebody to a hysterectomy. And quite frankly, I think it should be up here, where you're working up your other causes of chronic pelvic pain. So often hysterectomy is just not the cure. Chronic pelvic pain, like we said, very common. There is this little study, 2011 Obstetrics and Gynecology, and they found that chronic pelvic pain affects a lot of women. And when they look at the pathology, again, they're finding that 21 to 40% of women who have a hysterectomy for chronic pelvic pain still continue to experience pain after they've had their surgery, and 5% of them get new pain. So this really, again, is just not the complete answer for these folks. When you search for pelvic congestion syndrome in the Green Journal, Obstetrics and Gynecology, pelvic congestion, there's insufficient evidence. Yeah, maybe there's a cause-effect relationship. We really don't know. We don't have any good studies. So we're not going to give it much credit. And there's really not anything you can find in our literature about this and what to do for it. When you look for May-Thurner in particular, it's all associated with thromboembolic disease, and it's a rare condition, only associated with extensive DVTs. This is an interesting little statement as well. When you look at patients who have had extensive thrombosis, particularly in the 3rd trimester of pregnancy, where they've clotted off their iliac vein, and they say, wow, look at that, they've got May-Thurner, that rare thing. They stent patients because it's appropriate, but they just don't know what to do for them in future pregnancies. There's actually no protocol for that, no management. Thankfully, CVM is going to help to answer this question for them, because they've looked at patients who've gotten pregnant post-stent. Thank you very much. When you look at the Gray Journal, the American Journal of Obstetrics and Gynecology, and again, you look at chronic pelvic pain, you look at pelvic congestion or May-Thurner, still not much there. So this little study was done in Switzerland, 2019. They looked at studies, CT scans that were done in women who were brought in for chronic pelvic pain. And what they looked at was 2,384 pelvic and abdominal CT scans to see if they could identify dilated vessels, ovarian and parauterines. They used 6 millimeters for their ovarian and their parauterine dilation cutoff. And it was retrospective. You know, the radiologist didn't know that this is what they were going to be looking for. And just on that little retrospective look through the charts, they found that dilated pelvic veins were present in 12% of patients more premenopausal than post. And the most common diagnosis was chronic pelvic pain of unclear etiology. So they felt that pelvic congestion is underdiagnosed and undertreated. Yep, pretty much. And being that pelvic congestion was first described in 1949 as symptoms of chronic pelvic pain due to dilated pelvic veins, in 2019, we still don't have much more to say about it on the GYN end. And I'm a gynecologist, so I'm not at all trying to, you know, dissociate myself from GYNs or diss anybody on, you know, what they don't know, but we just don't have any information that makes the workup and management of these patients any more useful. The etiology, they claim, is still poorly understood, multifactorial, both mechanical and hormonal factors. It contributes to a lot of patients who come in for pelvic pain, is their statement here. And their final statement is, we really need to have more robust data. We need to understand this better. We need to look at patients with regards to pelvic pain with, you know, venous disease, obvious things that we can see. And we really just have to make this more of an awareness in the gynecologic community. I think I'm astounded by how much the venous specialists know about this. And as I've gotten in and taken care of these patients, and I see them come back to me, and I'm blown away by what we can do for these patients and how many of these patients I had in my past life that really could have benefited from this. And I'm very happy to say, you know, that I'm part of this. Pelvic congestion syndrome should not be this archaic, yeah, wastebasket. Maybe it is. Let's write it off and work on getting you, you know, controlled until you get your hysterectomy. It's a real condition. It contributes to the symptoms in these patients. Diagnostic modalities have gotten so much better. You know, how much better has ultrasound gotten in the past 20 years? It's amazing. I mean, intravenous ultrasound, unheard of. Like, that's an astounding step for me. You know, what you can see there, venograms, what vein disease means for these chronic pelvic pain patients is that there are effective treatment options that don't include having to give your uterus away necessarily. And I am so grateful to all the work that's been done on this for these patients. We are such a big part of the puzzle here, and I would very much like to see our gynecologists get on board with this because we can make huge strides in these folks' lives. Thank you.
Thank you, Teresa. Thank you for an absolutely spectacular talk. I mean, we have gained so much from your participation in the pain centers and your leadership there. And thank you for summarizing it so well. So folks, it's the next speaker. It's really my pleasure and privilege to introduce Gaurav. Gaurav was busy stenting left mains when he finally saw the light. And he was like, hey, there's something more exciting, more interesting, and places where I can help people as much. And he's now been a part of Center for Vascular Medicine, which works in close association with Center for Vein Restoration. And he's been there for, I think, 6-7 years now, Gaurav. Yep. And also he is the medical director of Center for Vascular Medicine. He has now, over the last couple of years, seen the next light where under Dr. Pappas's guidance, he is contributing a lot more to research. And it's a pleasure to have you talk about your experience here, Gaurav.
Thank you. Thank you very much for those kind words, Dr. Lakhanpal. So my presentation is in two parts. First is the iliac vein stenting for pelvic venous disorders, and the second part is iliac vein stenting for phlebital lymphedema. So this is a diagnostic ovarian venogram, as Dr. Gibson pointed out, and traditionally pelvic venous disorders have been attributed to refluxing ovarian vein, reflux in the periuterine veins or the branches of the hypogastric vein. And the treatments have been designed towards that. And, you come across patients who had coiling done for these, their symptoms. And this is another example of a patient who came to us after having coils done in bilateral ovarian vein reflux done 7 years ago at a naval facility without any relief of symptoms. And that used to be the norm that the Center for Vascular Medicine followed. We would have patients who would come in with pelvic pain, and we would evaluate them for reflux in the ovarian and the periuterine veins. We would also look at their iliac veins to see if there's any compression or outflow obstruction. And the patients would undergo embolization, whether it was chemical or coil, and following that, we would reevaluate and invariably ended up stenting them for their outflow obstruction to have the patients achieve complete relief of their symptoms. So when we did a retrospective analysis of all the patients that we had treated, and we came up with this our paper, which was published in 2018, which is iliac vein stenosis is an underdiagnosed cause of pelvic venous insufficiency. And prior to that, I have to give credit to Dr. Doherty, who had published a small series of about 19 patients in 2015, in which he had looked at patients who presented with the chronic pelvic pain and had ovarian vein reflux and iliac vein compression, and they ended up just stenting the iliac vein outflow with the complete relief of a majority of these patients. So our study also showed the same. I'll go straight to the results. Patients who had ovarian vein pre-pain scores of 7.41, with stenting alone, it reduced to 1.48, and with stenting plus embolization, it was 1.63. So there was a slight better improvement in their visual analog pain scores in patients who had undergone stenting alone. So this kind of switched our paradigm to what we started doing subsequently, that we would have patients undergo iliac vein outflow, stenting done before we would put them on the table for embolization, provided they did not have any resolution of symptoms or partial resolution of symptoms. And this gave us our second study, which we published now, which is going to get published in the Journal of Vascular Surgery, was presented last year at the AVLS, titled Pelvic Venous Insufficiency Secondary to Iliac Vein Stenosis and Ovarian Vein Reflux, which was treated with iliac vein stenting alone. So this was a smaller study. We retrospectively looked at 38 patients. who had both iliac vein outflow obstruction as well as ovarian vein reflux, which was demonstrated on IVUS and venogram. And we only stented the outflow disease and followed up these patients. And the results showed that the pre-pain scores, which included pelvic pain and dysmenorrhea, from 6.86 improved to 1.7. And the dyspareunia scores improved from 4.3 to 0.41. So 29 of the 38 patients had complete resolution of their symptoms, which was 76%. And of the 9 patients who had persistent symptoms, there was 7 of those 9 had a pelvic reservoir, which suggested that there may be a role for the pelvic reservoir, which had caused persistence of symptoms or partial improvement of symptoms in these patients. So then a conclusion based on these previous 2 studies was that majority of the women with pelvic venous insufficiency secondary to combined iliac vein stenosis and ovarian vein reflux demonstrated complete resolution of their symptoms with iliac vein stenting alone. Hence, the iliac vein stenting should be performed as a primary therapy in this group of patients, and embolization should be reserved for women who had a pelvic reservoir and had a partial response to stenting alone. So I will follow this up with a case, an actual case that we just treated. One of the patients that we've just treated, she's a 37-year-old female, history of past medical history of anxiety, asthma, attention deficit disorder, and superficial venous insufficiency. She had undergone ablations for her superficial venous insufficiency in 2018, subsequently had recurrence of symptoms in 2019. She also has a history of spinal fusion in the past. She was gravid 5, para 3. Her BMI was 18.79. She was on Bomicort and Pro-Air for her asthma. She took Trazodone for her anxiety disorder and Adderall for her ADD. Her visual analog pain scores, pelvic pain was 6 out of 10 daily. Dyspareunia scores was 6 out of 10. Whenever she had intercourse, dysmenorrhea was 7 out of 10. She did have a history of vulvar varices when she was pregnant. And her lower extremity scores was 6 out of 10 on the right, 5 out of 10 on the left on a daily basis. Seat classification was C2. VCSS was 6 on the right and 5 on the left. And like all the patients who come to us for evaluation, patient underwent a transabdominal pelvic ultrasound, which showed a right common iliac vein diameter of 0.59, and the left common iliac vein diameter was 0.43. And she did have a left internal iliac vein reflux on the duplex scan. This was a venogram. You can see on the left side, there is a reflux in the hypogastric vein. There is the lumbar hardware, which can be seen, and maybe some flattening of the left common iliac vein at the junction. And this was her ovarian vein, dilated ovarian vein. And if you look long enough, you can see the filling up of the periuterine veins, laterals starting to develop going outside. So this is what we've been doing now. We've been documenting patients with pelvic pain with this and with a venogram, and then she underwent a intravascular ultrasound, and you will see she has significant compression of her left common iliac vein. The classic method is the right common iliac artery crosses over right here and is compressing the vein. And she actually did have some compression lower down into the external iliac vein too. So this was she had about 83% compression compared to her normal segment, and underwent a stent placement. She got a 14 by 160 millimeter Benova stent on her left side. And this is the venogram after the stent placement. You don't really see the refluxing hypogastric vein anymore. And this was the IVUS post stent placement, well opposed stent. And this is her follow-up, 8 weeks post-procedure. All visual analog pain scores were 0. So she's scheduled to have a telehealth now coming up in February, and we will keep following up on that. And this has been a majority of the patients that we've been treating for pelvic pain now have been treated in this manner, and we hope to come out with data probably by the end of this year or sometime middle of next year, when we have enough 6 months to 1 year follow-up data on these patients, unless Dr. Pappas gets us approved for the randomized trial. And then moving on to the second part of the presentation, which is, I will again elucidate that with a case. This was a 64-year-old male who presented to the clinic with complaints of left leg swelling, which had been ongoing for several months. He has a past medical history of cutaneous T-cell lymphoma, which is currently in remission, also has cluster headaches. He was seen at Center for Vein Restoration initially and was evaluated for superficial vein reflux, was found to have very minimal segmental reflux in his proximal calf bilaterally. And he was then referred to us for evaluation for his deep venous system, as well as was referred to lymphedema for lymphedema evaluation for a pump, fitting for a pump and possibly lymphedema therapy. He's a non-smoker, uses alcohol socially, and also occasional marijuana use. His medications included the use of Caffergard, which he used for his cluster headaches on a PRN basis. He was on the B side, BMI was 32.28. SEEP scores were C4A bilaterally. And this was his leg measurements. On the right, the calf was 38.5, on the left was 42 centimeters, about 3.5 centimeter difference. The ankle was 23.5 on the right and 29.5 on the left, about a 6 centimeter difference. And his VCS scores were 4 on the right and 6 on the left. Again, he underwent a transabdominal pelvic duplex scan. His measurements of the common iliac vein on the right was 0.9 centimeters in diameter, on the left was 1.1 centimeters. Now, if you pause here and look at the diameter measurements, you would say, does this patient need to go on the table for a venogram? Should we IVUS it? But he was in a lot of discomfort. If you look at his images, the pictures, that will probably, reinforce your belief that, this patient needs to be investigated further. So on the right, you can see his left leg, which is significantly swollen compared to the left. He has the dorsal hump. It was positive stemmer sign. And he had a significant difference in his measurements in the calf and in the ankle. And his shoe size was actually different when he presented to us. He had to wear a different size shoe size on the left because of his significant swelling. So the patient underwent a venogram. This was done in December 2018. That's the AP view on the left and the angulated view, RAO 30 on the right. You can see there's some venographic appearance of compression on the proximal right common iliac vein. On the left side, can't really see very well. There's a lot of bowel gas, but he does have some reflux on the hypogastric vein here bilaterally. And this was his intravascular ultrasound. So again, he did have significant compression, but it was more in the mid part of the left common iliac vein, right there. You can see it becomes like almost a slit. And the percentage that we got was 56.4. I think we undercalled it. It should have been probably more than that. So the patient underwent a wall stent placement. This was in 2018, prior to the availability of Vinovas or Vicis. It was a 22 by 70 wall stent, which is deployed into the IVC, extending into the proximal part of the external iliac vein. And this was his IVUS post-procedure. Again, we used to put it about a couple of centimeters into the IVC just to counteract the weak radial strength of these wall stents. And he did have some inflow disease, which he had left behind, but we thought we'll see how it works. So the follow-up leg measurements so the initial presentation was 42 centimeters in the calf and 29.5 in the ankle on the left. After about 10 weeks, he was down to 40 centimeters and 25 in the ankle. And this was almost a year out in 2019, November. His left calf measures 38, his left ankle measures 23. And his VCS scores improved significantly from 8 on the left and 7 on the right to about 1 bilaterally. And more importantly, this was his pictures. Is more impactful is the pictures, I'm sorry. Let me show you. So on the left side, you can see significant improvement in his swelling. This is and from the front, and this is from the back. And I put both the pre and the post side to side to show you how much the patient's leg swelling has improved. He is a completely normal leg now. He does wear compression stockings on an occasional basis. He never really got fitted with the lymphedema pump. He didn't want to use it. He never went to the lymphedema therapist. So this was purely on relieving his outflow obstruction that he had such dramatic improvement in his symptoms. So the take home is that before we subject anybody to just purely lymphedema, I think it behooves us to at least do a transabdominal or transpelvic ultrasound. And if the clinical presentation is significant enough, and IVUS is warranted. Thank you.
Thank you, Gaurav. Thank you for an amazing talk. Thank you. Next, we have Dr. Gagne. Dr. Gagne it's really a privilege to have you here, sir, talking to all of us, educating us. And he is, especially in the venous world, the deep venous world, Dr. Gagne is a force that everybody knows about. I tried to go through your entire introduction. I think we're already running late and everybody knows you. So please, let's get started.
Thank you very much. And it's a true pleasure to participate this year. Haven't had the pleasure before, but I've been very impressed with the meeting so far. Peter, thank you and congratulations. So I'm going to go over the results of the venous stent trials that have been with us over the last half dozen years. So we've already seen these are the patients of interest who may benefit from iliofemoral vein stenting. And we're asking these stents to participate and treat in the patients who have these severe compression lesions, but also patients who have these severe post-thrombotic lesions with scar. And thank you, Dr. Comarota, for these images. So let me go through the studies in order of FDA approval for the stents. The big differences in the studies are that at imaging at 12 months, some of the studies used venography, the remainder used duplex imaging, and then the patients enrolled. Most of the studies had patients with chronic disease and acute disease, DVT or DVT on chronic disease, but some studies had just chronic disease, and I'll point that out. So the Venovo stent system comes in 10 and 20 millimeter lengths. It was FDA approved in March of 2019. The study design was prospective, multicenter, non-randomized, as are all the stent trials in general. 170 patients were entered. The patients had to have a stenosis of greater than 50% on venogram and a CEIF score greater than 3 and a VCS pain score greater than 2. The patients had both post-thrombotic disease and compression lesions. You can see here the BMIs. Interestingly, compression lesions were more commonly treated in women than in men. May-Thurner was a common component in the patients in the vernacular study. And when you look at the treatment, the majority of patients underwent stenting of the common iliac vein, less so in the external and certainly less so in the common femoral vein. And we look at, there was a higher preponderance of common femoral vein stenting in the post-thrombotic patients than in the compression lesions. Finally, if you look at the mean lesion lengths, not surprisingly longer in the post-thrombotic patients than the compression patients. Interestingly, acute DVT was present in about 14 of the 162 patients we had data on. This was more common in the post-thrombotic patients than the patients classified as compression alone. And then finally, these are the stented lengths. The freedom from major adverse events was minimal. There was no significant complications in this trial. But if you see here, the primary patency was 88% for all comers. And when we break this down at 24 months between the groups with post-thrombotic syndrome and NIVL, we can see that the patency at 24 months for the compression lesions was 95%, somewhat less in the post-thrombotic patients at 73%, and there were no stent fractures noted out to 24 months. So in conclusion, the vernacular study showed a primary overall patency at 24 months of 84% with no stent fractures, and the patients clinically saw improvement on their VCSS pain scores and Civic 20. Now, the VERTIS trial and the Vici venous stent, now commercialized by Boston Scientific, was the next stent to come out from with FDA approval. This is a high crush resistant stent available in 12, 14, and 16 millimeter diameters. It is available in a dual or two different delivery systems. One deploys the stent from distal to proximal. The other deploys the stent from proximal to distal. The VERTIS trial design was a prospective multicenter single-arm study, non-randomized again, for a total of 170 patients. The key inclusion criteria again was a 50% reduction on venogram of the diameter, a severity score of SEEP clinical score greater than or equal to 3, and a VCSS pain score greater than or equal to 2. You can see on the left, the distribution was largely post-thrombotic in 3/4 of the patients, so a challenging patient group. And you can see on the circle on the right that 31.8% of the patients had extension of stents below the inguinal ligament into the common femoral vein, so a challenging patient cohort. And these were all patients that had chronic disease. There was no acute DVT in this study. You can see that the primary patency at 12 months was just under 80% in the post-thrombotic group and 96% in the non-thrombotic group. And if you look at the improvements in their VCSS scores, you can see compared to baseline here versus 12 months, a significant improvement. And you can see that those patients with the most severe VCSS scores and disease had marked improvement over the 12-month follow-up period. So the Vici stent is a crush-resistant stent tested in patients with chronic venous outflow tract obstruction in the iliofemoral veins. The majority of these patients had post-thrombotic syndrome, and a large number of them had extension of the stent below the inguinal ligament. The non-thrombotic patients had 12-month patency of 96%. The post-thrombotic patients had patency of just under 80% with good results at 1 year. At 24 months, you see consistent improvement in these patients with patency and 73% in the post-thrombotics, 96% in the non-thrombotics. There was some target vessel revascularization and stenosis noted. However, remember that this study, unlike other studies on the venous stent trials, we're using venography, which is more sensitive for detecting this, and therefore the clinical significance of this finding is not really clear at this point. Now, interestingly, the venous wall stent commercialized by Boston Scientific was approved by the FDA in 2020 for iliofemoral vein stenting through a different route than an IDE trial, using available literature that has been published about venous stenting with the wall stent for the last decade or so. We're all very familiar with the wall stent. We looked at the long-term clinical outcomes of the wall stent for this purpose a few years ago and published this, with the idea being that as we get nitinol-based stents, will that change our practice? And so we went ahead and looked at 67 patients who we had placed wall stents in and had long-term follow-up. And this was for chronic disease, no acute DVT. And this was our primary patency. Here, it was approximately 80%. And what we saw for that entire cohort was that our non-thrombotics, not surprisingly, did better than our post-thrombotics, and the breakdown of patency is similar to what we've seen in the nitinol stents. And it was in the same cohort, SEEP3 through SEEP6, we saw a reduction in the SEEP scores, and the VCSS scores dropped as well, much like in the nitinol-based studies, nitinol stent studies. So I think the wall stent has a role to play, and that'll be determined over time. The Abre stent by Medtronic was the next approved by the FDA. I thank Aaron Murphy for sharing these slides. This is a nitinol self-expanding stent system, the Abre stent. This was a prospective multi-center non-randomized single-arm study, as were the other IDE trials. 200 patients were enrolled at 24 sites around the world. Dr. Black and Murphy were the principal investigators. You can see here the demographics on the bottom left pie chart, compression lesions in 36%, PTS or post-thrombotic syndrome in 17%, and 47%, and acute DVT in 17%. The left leg was most frequently intervened on. So this was a good cohort of patients with real world experience. You can see that stenting here involved in the common iliac and external iliac veins frequently, consistent with post-thrombotic disease, but oftentimes there was extension down below the inguinal ligament to the common femoral vein in 44% of these patients. So this was a tough patient cohort representing what we see in the real world. And you can see here again, these post-thrombotic patients with extension of the stents to the common femoral vein. The primary endpoint, the safety had major adverse events in 2% of the patients, and primary patency at 1 year at 88%. When you look at the major adverse events, there was some stent thrombosis, not surprisingly in the patient cohort being studied, which was fairly low at 1.5%. When you look at the patient primary patency by the etiology of the outflow obstruction, the post-thrombotic patients had just under 80% patency at 12 months. The patients with compression lesions, better as generally they are, at 98% primary patency, and then the acute DVT patients in the middle with a primary patency of 87%. When you look at the extension, those patients who had extension of their stents below the inguinal ligament to the common femoral vein, there is some decrease in the post-thrombotic patients in patency, but not much change in the compression lesions or the acute DVT. This oftentimes being an inflow issue. So when we look at some of the secondary endpoints in this study, you can see that the primary assisted patency in these patients is excellent. And there were no stent fractures noted over the 12 months of the study reported to date. But there was significant clinical improvement based on changes in the Volta scores and the VCSS scores. So the Abre trial testing the Abre stent shows excellent primary patency at 88% overall, with expected improvement in the three groups of patients with outflow obstruction and minimal major adverse events. There was good success in the trial, and these stents performed very well when extended down to the common femoral vein. And there were no stent fractures. Finally, the Vivo clinical study. This was Cook's Silver venous stent. It was actually the first of the venous stent trials to start, and they received FDA approval for their stent in July of this past year. These stents are available at 14 and 16 millimeters in diameter. I'm sorry about the shift here as we transferred to the video today and the shift of that. These slides appear to be jumbled, so I apologize. This was a similar study design as the nitinol stents we've talked about, a prospective non-randomized multi-center trial. This included both patients with chronic disease, acute DVT. Different than the other studies, the Vivo study trial required that 30% of the patients present with acute DVT. They also had to have a CEAP clinical score of greater than or equal to 3 and a VCSS pain score greater than 2. You can see that the significant majority of these patients had a acute DVT, 49% at the time of the procedure, and had a history of chronic DVT or DVT at the time of treatment. So a significant number of thromboembolic events in this group. And you can see that the stenoses were largely due to chronic obstruction in 30% of the patients, and then the distribution here. And again, this slide appears to have been jumbled as it went to the central server. Most of the stents were placed for common iliac vein compression, as shown here, and then more commonly in the left leg where the vessels treated, left common iliac vein. But again, a significant number of patients treated to the level of the common femoral vein in this study. Now, as I mentioned, the studies that had a venogram follow-up at 12 months, which was the VIVO study and the VIRTUS study, you saw excellent follow-up at 12 months with venography in the VIVO study. And you can see that there were some in-stent stenosis that was noted. This was the first study of its type being done. And again, I would mention that the sensitivity of venography for these lesions is going to be higher, and the clinical significance remains unknown. Finally, the 12-month primary patency was 89.9%, just under 90% for all of this group of patients with chronic disease, acute DVT, and acute on chronic. And there were no stent fractures in the study. This was the improvement in the VCSS scores from baseline over 12 months. You can see a good clinical response. So the VIVO study had a complex patient group of patients, as did some of the other stent trials with acute on chronic, and chronic non-thrombotic patients. They had just under 90% primary patency at 12 months without stent fracture and with low reintervention rates. So in conclusion, when we look at the 5 venous stents approved over the last few years, we have the wall stent as the only eligible stent, and then the 4 nitinol stents. The Cook Vivo, the Medtronic Abre, and the Bard vernacular studies had a mix of patients with acute and chronic DVT and scar, as well as compression lesions. The VIRTUS study was chronic disease alone. The Vivo and VIRTUS studies had venogram at 12-month follow-up, so therefore seemed to have a slightly increased detection of in-stent stenosis compared to duplex ultrasound and the other studies. Whether that's symptomatic, clinically significant or not is unclear. You can see that in general, the patency is somewhere between 84 and 89% for these stents overall, if you take all comers, with consistent clinical improvement once you restore flow through these vein segments. The Vivo and Abre stent trials seem to have the highest extension to the common femoral vein without any fractures. And then all the stents are offering a 14 to 16 millimeter diameter, which is probably the most common stent size used clinically. Thank you.
So thank you very much, Paul, and all of the speakers for this session. These are high quality, phenomenal talks. Unfortunately, for the sake of time, we're not going to be able to have a panel discussion for this session. So for all of the participants, if you have a particular question for the speakers, please use the chat room, send them your questions, and the speakers will answer you directly. At this point, we'd like to move on to the last part of our session here, which is the presentation of this Susutra Award. So Rick and Dr. Lakhanpal and Dr. Nguyen are going to discuss our award recipient this year. Dr. Lakhanpal.
I think Rick's going to go first.
All right.
Thank you. Thank you both. Thank you, Peter. And again, congratulations on the President's Award, Peter. Very well deserved. I'm honored to be here today on behalf of the Lakhanpal Vein Foundation. The Vein Foundation was formed in 2014 by Dr. Sanjiv Lakhanpal with a mission of engaging in cutting-edge research in the field of venous and lymphatic medicine. The relentless drive to publish was given to Sanjiv by his father, a radiologist by training and a lauded clinical leader in northern India. And in fact, the foundation's name was designed to honor Dr. Lakhanpal Sr.'s vision. Over the past 2 years, the foundation has undergone a revitalization of its mission, and as a part of this, has engaged in a number of activities designed to bring about development, growth, and reinvigorated purpose of the organization. The board of the foundation has grown to include many prominent civic, community, and clinical leaders, and we meet together to discuss board composition, the organization's mission, and fundraising development opportunities. Most recently, the foundation and its leadership have been exploring opportunities to engage in philanthropy in the formation of the creation of wound healing centers in the developing world, initially focusing our efforts on the Indian subcontinent. Much activity has already gone into this endeavor, and we're excited to be able to update you in the near future about our progress. Most recently, the organization has welcomed a new team member, Ms. Nidhi Lakhanpal. Nidhi comes to us with a wealth of experience in business management and accounting, and she's passionate about our research and our philanthropic missions, and we're happy to have her. 3 years ago now, the board of the foundation expressed its desire to develop an award that recognizes an individual who has contributed in a very significant way to the field of venous and lymphatic medicine. Thus was born the Sushruta Annual Award, presented by the Lakhanpal Vein Foundation. Sushruta is generally recognized as the father of medicine and developed many surgical procedures in the 6th century BC, which are still recognizable today and are the basis of what we see in modern surgery. Ironically, the name Sushruta in Hindi is an epithet, which means to be renowned. Many may remember that the inaugural award was given to Dr. Raju 2 years ago for his lifelong contributions to our field and to his patients. And this past year, we welcomed Mr. Dean Bender, the Executive Director for the AVLS, into the ranks of the Sushruta Award recipients. And now I'm honored to invite Dr. Sanjiv Lakhanpal to join us to announce the Lakhanpal Vein Foundation Sushruta Award recipient for 2021. Dr. Lakhanpal.
Thanks, Rick. So guys, as we embarked on our journey with the Center for Vein Restoration and then the Center for Vascular Medicine, you know, with my background in cardiac surgery, I just did not have the knowledge that is needed to really come up with the right kind of an organization leading the field of venous and lymphatic disorders. So we had to really rely on a lot of people. Early on, it was Dr. Sufyan who helped us out, who helped us educate. And then next, before we had the honor of meeting Peter, in fact, Nikos is the one who introduced me to Peter. Nikos would come here and try to, teach us all. By that time, we were at about 10, 15 clinics. And Nikos would take all the effort and driving from one office to the other office with one pure intention of making sure that we are delivering excellent care to the patients. I still remember him saying so many times, Sanjiv, promise me that you're not here just to make money and you're going to do better things. And Nikos, I hope every day we try to keep that promise and try to make you proud. I remember our drive down to Prince Frederick one day, and I will not publicly say what you told me, but every one of those things we still remember, and we are trying to strive to get to a place where we meet the standards that you've laid down for all of us. And another little anecdote, when growing up in India, when I would go through medical school, and there'd be some other people with IQs as high as Nikos who could just state all the studies, so-and-so has done this study in this year, and I would just look around, what the hell, how do I compete with somebody like Nikos? And then a friend of mine would say, okay, you just need to know 2, 3 names of people who publish all the time, and just name a study based on so-and-so. And if that was the world of venous disease, that name would be Nikos. That, hey, Dr. Labropoulos has said that, and then say whatever, and the world would believe it, because you have published so much. You have educated us all so much over the years. And the excellence that you strive for is exemplary for all of us. And growing up in Greece, then going to the UK for your training, and, then teaching all of us. And while you teach us, you even come home and cook for us. I mean, where else can we find a friend, a teacher, a mentor like you? Thank you very much, Nikos. It's our honor to present the Vein Foundation Award to you. And Ken, who's been a part of all this journey with us, would also like to share a few words in your honor.
Hey, Nikos. Hey, buddy.
Hi.
Congratulations. If there's ever a perfect match for this award, I would say it's got to be you. You have had a part in everything we do, everything that the field does for venous disease. And if you know, as I go through our protocols and look at how our offices run and look at how our vascular techs do their scans, you have had a piece of that, and we thank you. So congratulations on this honor, and thank you for your contributions to the field.
Peter, I know you and Nikos are very, very close. I'd love for you to say a few words in Nikos's honor.
Oh, thank you, Rick, Sanjiv, and Ken. It's with great joy and love in my heart that I've been given an opportunity to talk about my friend Nikos Labropoulos. In my opinion, Nikos is the closest thing to a clinical genius I've ever seen in my entire life. I've had the blessing to have been introduced to Nikos over 25 years ago. Nikos was still a graduate student at the time with Dr. Nicolaides, and I was a fellow during my second year of clinical work. And Dr. Nicolaides introduced the both of us during one of the American Venous Forum meetings. We were having lunch together, and since that time, we've been closest of friends. Nikos's work is unparalleled. His numbers of publications have had the greatest impact in terms of clinical decision-making of any one individual in the venous world that I can tell you about. Nikos is also the closest thing to a venous ambassador that we have. He literally travels all around the world, not because he wants to increase his fame. He's already been renowned around the world, but because he's passionate about educating other doctors about venous disease. And he really is an ambassador in all the positive ways that you can possibly think of. Nikos also, his commitment to education is not only on the academic level. Because I know him personally, Nikos has mentored countless college students, medical students, residents, to help them along their career paths, to help focus them in their desires, to help them do research and clinical work. And he does it without asking anything in return. It's based out of a pure desire to give back to the world. And this is just part of his overall character. And finally, that you could not ask for a more loving, loyal, kind friend than Dr. Labropoulos. Once Nikos considers you his friend, you are essentially a family member to him. He and Tony are two of my closest friends in the world, and nobody deserves this award more than Nikos. And I'm very, very happy on his behalf that he's been awarded this award today. So Nikos, congratulations from the bottom of my heart. Well deserved.
This is the plaque, Nikos. It's going to be virtual, sorry, but hopefully one of these days we'll get your famous hug, and we can have the honor of awarding you this plaque in person.
Sanjiv, thank you very much. Peter, thank you for your kind words. I remember, Sanjiv, the humble beginnings, and I want to congratulate you on the CVR 100. What an achievement. For all of us within CVR and out CVR, it's good to dream, you know. It's good to dream and look ahead and create so many good things. And over the time to enjoy who you are, what you do, and have fun in your life. And congratulate you, Peter, for your award today, and also for a spectacular scientific day of the highest quality. Guys, you're doing a great job. Continue, dream on, and do better and better. And very humble and extremely appreciative for your award. Thank you so much.
Thank you, Nikos. Thank you, Peter. Thank you, Rick. Thank you, Ken.
Well, guys, you know, it's another year has gone by, and another CVR Vision Conference has come to a conclusion. You know, as I was watching all these presentations, I just cannot help but think about all of the extraordinary people that have helped in some way or another to make this a success. I get a little bit teary here with all this, you know. But just an FYI, this morning when I logged on, and at 7 a.m. in the morning, we had over 800 registrations at that time. But we always think, you know what, 800 people register, you know, how many people are really going to show up? And to my surprise, we had over 600 people sign in at 6:59. That's unbelievable. So thank you all for waking up at 7 a.m. Thank you all for being there to support us. You do not understand how that support means, or how much that support means to us. And whether you're a competitor, whether you're a referring doctor, whether you're one of our staff, or whether one of the people who are just interested in venous disease, or one of our sponsors, being there for us means more to us than you can really imagine. So I'm just going to go through a list of thank yous. And I know that I'm not supposed to do this, but I will tell you that I've always felt that if I don't have a list, then I'm gonna mess up somehow. And you know, there's always going to be somebody that I miss. And I hope that you guys know that we appreciate everybody, but I think there are certain people that we just have to thank. So to our vendor partners, Tactile, Medi, Boston Scientific, Bard, Medtronic, this event really would not be possible without you guys. I know that this year has been tough for everybody, including all of you. You guys really, really stepped up in a big way, and we really appreciate it. And to all of the amazing speakers that took time out of their day today to present, your expertise, your experience, your generosity, and sharing what you know was very much appreciated. And thank you very much. To all of the CVR clinical staff, you know, the doctors, the nurses, the vascular techs, the admin, all of the operational teams, the financial teams, the IT, the HR, the sales, the marketing teams, I can go on and on. But I will tell you that CVR is what it is because of all of you. And thank you for giving Sanjiv, myself, the rest of us the opportunity to be servants to you and to be able to show the world what CVR's talent is all about. And finally, I will tell you that this is the hardest part of the presentation. All right, there are times when the words thank you really just don't suffice. They really don't. They just don't portray how I feel about certain people. And sometimes our teams do such an amazing job and make such a difference that I know that Sanjiv and I, our gratitude is so profound that a pat on the back just is not good enough. And this is that time. So Dr. Pappas, Vinny, Manzoor, Elizabeth, Kate, Kim, Vincente, Alana, Jonathan Lay, John Feltz, Jessica, Antoinette, and John from Morning Tomorrow or Meeting Tomorrow. Thank you very much for everything that you guys do. Just know that this thank you means a lot more than just thank you. And with that, guys, we are going to conclude Vision 2021. For all the CVR folks, let's crush it in 2021. And we're going to be back in 2022 in person. Have a great year, everybody.
Bye.
Bye, guys.